Hey, everybody. I just wanted to thank you, everybody, for joining us this evening for our webinar today. We have put together this great webinar titled Disparities Among Head and Neck Cancer Patients Moving Towards Patient-Centered Understanding. Myself and Dr. Maddie will be your moderators for today. And just as a preview in terms of how this will be structured, we'll have 4 great talks by our experts, and then we'll have some discussion afterwards. If you have any questions at all, please feel free to use the question and answer portion of it. We'll be moderating a discussion at the very end of the talk, but have the questions flowing in throughout the talks as they come up, and we'll be happy to address them at the very end. So just before we begin, a little bit of context about this webinar. When we had been talking about putting this together, Dr. Maddie and I had thought that there was a lot of interest in looking at disparities among head and neck cancers, but really our desire was to have a better understanding of exactly what was driving these disparities and what type of things might be actionable items that we can do in order to then lessen the disparities, both on a patient level and on an institutional level. So these talks have been put together to kind of get an understanding about the background and the basics of disparities research in both head and neck cancer and cancer in general, as well as highlighting some efforts that are being made to lessen disparities among our patients. So we'll start the webinar with a presentation by Dr. Sykes. Dr. Sykes earned his PhD in health policy and management, looking at healthcare delivery for the medically underserved in clinical trials management. Currently, he works at Baylor Scott & White as the Director of Clinical Research for Health and Wellness, and has previously worked as the Director of Clinical Research in the ENT department at the University of Kansas Medical Center, and he'll be talking about race as a social construct.
All right, thanks everyone. Thanks for the opportunity to be here today. I'm excited about this panel, not only for the opportunity to share my thoughts and kind of contribute, but also for all the talks that we're about to hear. I'm excited about what we're gonna see, having previewed all these slides. I know there's a lot of interesting content that's going to come forward, and I hope you will all stick around and hear everybody. So just to give you a little bit of context, I am presenting this as a white man, recognizing fully that as a white man, I have certain privilege, and that privilege has come with benefits that are sometimes easy to measure, sometimes harder to measure. And so I come to the table saying that as a white man, I'm in pursuit of an anti-racist agenda in my life and everywhere else that I am working. And I hope that there's some grace in there if I make mistakes. I am confident that I will along the way and have. And I come to this with that sort of humility, hoping that we can all learn something together and work together for those solutions. So I've been kind of tasked with talking about race and what it means. And I'm going to steal from Dr. Jones here, who has really kind of put it to a fine point and has brought the title that was given to my section really into strong language. So race is a socially constructed way of grouping people based on skin color and other apparent physical differences, which has no genetic or scientific basis. Next slide, please. So when we talk about race, we do want to recognize that the origins of even the term itself and the construct of race is based in the transatlantic slave trade from the late 1600s. So this really comes from this idea of oversimplifying biological variability and really doing that for the purposes of European colonialism, oppression, and discrimination. So the idea of race as a phenotype really is to highlight the differences, mainly to create a hierarchy. Next slide. So race ethnicity in the United States kind of comes down these government levels, which really informs a lot of the work that we do in medicine and the work that we do in research. And so when you look at what the Office of the OMB, we'll do it that way because it's easier. The OMB from 1997 statement that really informed the development of the census in its current form, they state that categories represent a social, political construct designed for collecting data on the race and ethnicity of broad population groups in this country and are not anthropologically or scientifically based. So again, we're just reiterating the same thing that's been said before. And the census recognized after kind of reconstructing itself in the 90s, the late 90s, that there's going to be 5 major racial categories at minimum, and then only 2 ethnicities. So it's an interesting idea and choice that was made by a whole group of different experts, and particularly from well over 100 agencies that contributed to this conversation and some public comment that give us these 5 major racial categories, and then non-Hispanic and Hispanic or Latino as the ethnicities that we are willing to recognize on the census. But they did place an important emphasis on self-identification. And I bring all of this up to say that when we talk about race and we talk about the categories of race in research or in health disparities, it really should be based on individual self-identification. And when we're doing anything other than that, we're taking the risk of miscategorizing people into groups that don't align with their identity. Next slide. So how do we handle race and ethnicity as variables in disparities? It's unlikely, however common in history, that we would refer to these as biological or genetic differences. And it just oversimplifies things down to these categories of what is really going on in someone's life and ultimately driving the disparity. So we can say, oh, well, it's a biological or genetic concept as a racial category, but then it's really more likely that what's happening here and the disparities that exist, the driver is really the societal treatment of these minoritized individuals. It's not some sort of biological or genetic factor, generally speaking. So consequently, we could remove them from scholarship. However, that runs or puts us at a pretty high risk of obscuring our view of racism as it relates to people's individual identity and how that plays out in their lives and how they experience healthcare in the United States or in other parts of the world as well. Next slide. So when we talk about racism, which is what we really should be talking about when we talk about these categories of experiences that people of different racial identities go through, we should recognize that this is a systemic barrier to health and thriving. And I know that some of the upcoming talks will get into these more upstream drivers, if you will. But we have to understand that because it is a systemic barrier to health and there are structural biases that are at play, then we have to recognize that we need a systemic lens to ask questions about what can we do to solve the problem. So a starting point might be questioning racialized discussions in medical education. It might be provider-focused unconscious bias training or diversification of the workforce. To be honest, some of these are better than others, but they're starting points. We can't be satisfied with these as the ultimate solution to the problem. We have to have a much broader conversation, both at a policy level and also at a sort of, I guess you could say, cultural reconciliation perspective as well. Next slide. So there are some easier opportunities, and some have published on this work, particularly in pediatrics. There has been a group that has gone through and examined all of the clinical practice guidelines for racial bias. And they've gone through and highlighted in this paper here that's cited at the bottom, it talks about each of these, and it talks about the ways in which race is used within these clinical practice guidelines and might be misused and might be inappropriately used. So next piece would be underrepresentation in genomics cohorts. And the reality of this world is that those people who are unable to participate in genomics cohorts stand to benefit less from the movements of precision medicine and the things that are coming with the promise of some of these genetic genetic-based treatments, et cetera, et cetera. Next slide. And I always like to use this slide to kind of highlight where we're at as it relates to representation in clinical trials and clinical research. We know that there's a disproportionate number of white individuals who participate in clinical trials, and we know that these opportunities are less commonly available to some of these minoritized populations in the world. And so we need to do more work to make sure that we're highlighting these opportunities for individuals as they come through clinics, as they come through hospitals, but also we need to do more work in meeting them where they're at and understanding the barriers that they have to medicine, as well as barriers they have to clinical trial participation. Next slide. So there's some kind of high level things that we always talk about in the context of race and using race in medicine. EGFR and racial corrections, which we know to be based on an extremely small cohort, and recognize fully that that's unlikely to be representative of the Black race as a whole. And so there's a lot of questions about what value that calculation and the corrections bring to the table. Similarly, the corrections that exist for Black and Hispanic and Latino individuals who are giving birth, we have this adjustment that happens for the risk at the associated risk attributed by these corrections or calculations for vaginal birth after cesarean. And finally, suggestions of racial differences in COVID-19 prognosis were early on presented as these kind of genetic markers or biological markers for bad prognosis just based on someone's race. And we know that that has no basis in reality, with the exception of the fact that people identifying in these minoritized categories may have experienced a whole host of other social and political and structural barriers to care. Next slide. So finally, what are you really asking when you ask about race? Are you asking for race as a proxy for genetic ancestry? Are you asking for race as a socioeconomic position? Are you asking it as a marker of social characteristics or behaviors? When we know that the table on the right, or the sort of diagram here on the right, represents a pretty largely or widely accepted breakdown of what factors do as it relates to health outcomes. And we ask these questions of, what is the point of asking about race? Are we truly asking about racism? Are we asking about something else? And if that's the case, then we should probably be gearing our questions toward those items rather than using poor proxies for other variables. So I'm going to leave it at that, and hopefully that will set the table for the upcoming talks. But look forward to your questions and the talk as it goes on. Thank you.
Yeah, so I think that's a great segue to Dr. Gomez's talk. So Dr. Gomez is a professor in the Department of Epidemiology and Biostatistics at UCSF and a member of the Helen Diller Family Comprehensive Cancer Care. She is part of the Population Sciences Program and Leadership Committee for the Prostate Cancer Program. She's an epidemiologist with research interests, especially in the role of social determinants of health, including race, ethnicity, SES, gender, et cetera. And we'll really be talking about exactly this problem that Dr. Sykes had brought up about how when we're measuring race, we're actually measuring, we're using a proxy of something else.
Thank you, Dr. Tam. And that absolutely was the perfect setup for my discussion. And I also really love Dr. Sykes's preamble. And I'll just say everything that he said regarding acknowledging my position of privilege and that I'm coming from what I'm about to present from that particular position. Next slide, please. So as an epidemiologist, I'm really approaching this from the question of what exactly are we measuring and what's the best and most responsible and appropriate way to measure these these measures. So with that, my lab at UCSF have been using this particular framework that recognizes that there is a continuum of influences on health outcomes ranging from upstream factors, structural determinants that we know are unfairly distributed and allocated to population groups in the sense that they are less available, and that there are racist and various isms that determine how these resources are distributed across groups within our society. Next, please. And so we commonly think of, and everybody has heard of the term social determinants of health. We have been trying to move away from using the term determinants to using the term drivers, in the sense that these conditions in which people are born, grow, work, live, and age, as defined by the WHO, are not necessarily deterministic of our health, but certainly they can drive opportunities for engaging in healthy behaviors. Next, please. But we can further move upstream and recognize that there are structural drivers of health, which are the wider set of forces and systems that shape the conditions of daily life. So what Dr. Sykes mentioned about what are we really talking about when we're talking about race, this really is race and other minoritized statuses, and the intersections of those statuses really are experiences of how these resources are distributed, and that we recognize that they are structurally driven. Next, please. And so one of the consequences of the COVID pandemic was that there was much broader acknowledgement of the impacts of structural racism and how it drives inequities in health among population groups. And so as a result, over the past couple of years, there were actually some really helpful editorials and commentaries and guidelines that have been published in the public health and epidemiologic literature for us about how we can think about structural racism and concepts of structural racism. So I'm going to focus on one aspect of this in terms of the research that my group has done, focusing on measuring one particular domain of structural racism, here looking at residential segregation and housing discrimination. Next, please. And so in partnership with our colleague, Kirsten Beyer from the Medical College of Wisconsin, what we've done is we've taken data from the Home Mortgage Disclosure Act, and we've calculated two indices. These are contemporary data, so they are measuring current patterns and trends in mortgage lending patterns. The measure of index of redlining is based on a model that calculates the adjusted odds ratio of mortgage loan denial within a particular census tract. So this is a relatively small geographic region compared to those outside of that census tract, but still within an MSA, generally speaking, a city boundary. And these models are adjusted by sex and loan to income ratio. So if we see that the index is greater than 1, it indicates that that neighborhood is more likely to be denied a mortgage application than its surrounding area, all else being equals, because this is adjusted for loan to income ratio and other applicant demographic characteristics. Next, please. The second measure that we're interested in looking at, also calculated using this HMDA data, is called a racial bias in mortgage lending. So what this one is doing now is it's calculating, also within a multivariable model, an adjusted odds ratio for denial of a mortgage application. And we can look at any two particular population characteristics. So for this particular study, we were interested in asking whether Black or African-American applicants were more likely to be denied a home loan compared to a white applicant. And again, these are for a multivariable model, so they're adjusted for sex and the ratio of the loan to income ratio. Next, please. So we've applied these measures to one particular study. It's not head and neck, but it's certainly applicable, I think. So this particular study is looking at prostate cancer among African-American men. Next, please. This is a part of a study called RESPOND. It's a large national study in which we are addressing the question of laid out within this conceptual framework for whether a multi-level life course stressors that are indicators of structural and social drivers of health, if they impact upon prostate cancer outcomes. So within this conceptual framework, we posit that at the most fundamental cause of prostate cancer aggressiveness and mortality among African American or Black men is due to structural racism. And structural racism impacts upon social stressors at various levels, including at the contextual level, at the individual level. And then there are different pathways by which it can lead to prostate cancer outcomes. One of the particular pathways we're interested in is in stress, which is embodied and can impact upon biology. Next, please. And so this is funded through a multi-project program project grant. The lead is Chris Heyman from USC, and my group at UCSF is leading one of the projects. And it's we really envision this as a cells to society type of model in which we're looking at germline genetics and its interactions with prostate cancer genomics and these multi-level structural and social determinants of health. Next, please. And so just to kind of give you a sense of what kind of data we're measuring. So this is really, again, speaking to what Dr. Sykes was mentioning about now how can we really start to move to really measuring what we think race is measuring? And so we administered a survey. We have just finished enrollment. We have enrolled over 12,500 African-American men newly diagnosed with prostate cancer from 7 states across the US. And these are the types of data we've collected from that survey. Next, please. And then through geocoding their addresses at diagnoses, we've laid on linked in area level measures of contextual level social stressors, including those 2 indices of structural racism that I mentioned, in addition to some of the other social and built environmental factors that are listed here. Next. And I just want to show you the distribution of one such measure. And so this is looking among African-American and non-Hispanic white men with prostate cancer. From this cohort, these are along the x-axis at the bottom, you can see the 7 states that are geographic regions that we included in this study. The last 2 sets of bars are for everybody combined within this cohort. These sample sizes, which I unfortunately did not show here, are upwards of tens of thousands of African-American and non-Hispanic white men with prostate cancer. So this is the index of racial bias and mortgage lending, calculated from the Home Mortgage Disclosure Act data. If the value is greater than 1, so that's anything in the lighter bars, that indicates that that particular neighborhood that the prostate cancer patient is living in has a higher odds of mortgage loan denial compared to a white applicant. And what we can see largely across the board, regardless of which area we're talking about, which state we're talking about, that the vast majority, upwards of 90% of areas that these men live in indeed have a higher odds of mortgage loan denial for Black versus a white applicant, and that this odds can go up as high as fourfold, if not greater. We do definitely see a greater disparity in some regions compared to others. For example, Detroit and New Jersey seem to have particularly high segregation with regards to where the types of neighborhoods that African-American and white men live in. And so we are conducting analyses that are aiming to assess whether these upstream factors, such as this measure of racial bias in mortgage lending, is associated with prostate cancer outcomes and the extent to which that may be mediated by specific neighborhood characteristics as well as tumor genomic factors. Next, please. And so what do we do about this? How can we really affect change? And I think the next speakers will really touch on this. And so just very briefly, I want to refer you to this really nice report that was put out by the National Academies of Sciences called Integrating Social Care into Healthcare Delivery. And they talk about translating this into the 5 A's of social care: adjustment, assistance, awareness, alignment, and advocacy. And I like how this 5 A's was laid out in that we could think about these interventions in terms of activities focused on individuals as well as activities focused on communities, and spanning both levels as well. Next, please. And that was all that I had. Thank you.
Thank you so much. Dr. Maddie, did you want to take over?
Yeah, well, thank you, Dr. Tam and Dr. Gomez and Sykes for your insights already, and the AHNS for really providing this platform for these really important conversations. And I'm delighted to introduce the next speaker, Dr. Megwalu. He is originally from Ottawa, Canada, but spent most of his childhood in Nigeria. He's a professor in the Department of Otolaryngology at Stanford and has an interest in health outcomes and health services research, including, of course, health disparities, to the topic of today's talk, and head and neck cancer epidemiology and comparative effectiveness research. I think it's really incredible to highlight that he was recently appointed to the National Academies of Sciences, Engineering, and Medicine's Committee on Meaningful Outcome Measures in Adult Hearing Healthcare. So a tremendous accomplishment, and so excited to have you participating. And he's going to lead us into his topic of patient engagement to improve the delivery of cancer care in underserved populations.
Thanks, Dr. Mari, for that introduction, and just thank you for the privilege to talk on this very important topic of health disparities. Next slide. So I don't have any disclosures for this portion of the talk. Next slide. So I think before we can start, thinking about how we can reduce disparities, we have to actually understand the drivers of disparities. There are two main conceptual frameworks for understanding disparities. The first is a global public health framework that focuses on looking at the social determinants of health. The second framework is a healthcare system framework, which focuses on looking at differences in quality of care and how those drive disparities in outcomes. I think for us to understand the drivers of disparity, we have to acknowledge that these drivers are multifactorial and they occur at multiple levels, including individual level, the community and neighborhood level, as Dr. Gomez already talked about. We have to look at the provider levels, just looking at things like personal prejudice, as well as cognitive bias. We have to look at also the clinical encounter and how the factors of both the patient and the provider and the interaction of those factors, how those can drive disparities. And then we also have to look at the healthcare system. There are systemic inequities in the healthcare system that help drive disparities. Next slide, please. So this diagram here represents my very simplified framework for understanding racial disparities in head and neck cancer. And as you can see, it's pretty complex. Essentially, there are two main pathways here. Next slide. So the first pathway tries to look at racial disparities as a function of differences in disease stage of diagnosis. Next slide. And the second pathway tries to understand the persistent disparities in survival and outcomes that we see even when we account for differences in disease stage. Next slide, please. So I'm going to talk about a study that we're doing right now that's looking at the relationship between race, insurance status, and socioeconomic status and quality of care, and how these factors drive disparities in head and neck cancer outcomes. So we're using data from the California Cancer Registry, linked with discharge records. And we were actually able to develop a composite head and neck cancer specific quality score that incorporated the hospital variables that you see listed there. And what we found was that patients that were treated in high quality hospitals had better survival compared with patients that were treated in low quality hospitals, as you can see on the Kaplan-Meier curves on the right. Next slide, please. And then we looked at how insurance status was associated with quality of care. And when we looked at hospital quality, we found that Medicaid and uninsured patients were less likely to be treated in top quality hospitals. We also found that Medicaid patients were more likely to be treated in bottom quality hospitals. We also found that neighborhood level socioeconomic status was also associated with where patients receive care, with patients from low socioeconomic status neighborhoods being less likely to be treated in top quality hospitals and more likely to be treated in bottom quality hospitals. And we examined NCCN guidelines compliant care for advanced stage disease. And we found that Medicaid and uninsured patients were less likely to receive dual modality therapy. Next. We also looked at race and ethnicity. And what we found was that Black and Hispanic patients were less likely to be treated in top quality hospitals and more likely to be treated in bottom quality hospitals. And we did a formal mediation analysis and found that insurance status and socioeconomic status actually mediated the relationship between race, ethnicity, and hospital quality. Interestingly, when we looked at guideline compliant care, we found that Hispanic patients were actually more likely to receive dual modality therapy, despite being more likely to be treated in bottom quality hospital. And the exact reason for this is not clear, but our theory is that this might be due to sort of differences in social support. There is evidence in the literature that there are cultural differences in terms of emphasis on support of family and relatives in terms of helping people navigate the healthcare system. Next slide, please. So let's talk about some of the potential targets for intervention in improving, reducing disparities. I think at the policy level, we can look at addressing health insurance, so in the form of health insurance reform. But I think it's important to not only improve access to health insurance, but also to improve quality of health insurance coverage. Looking at quality of care, some potential options include regionalization of cancer care, so limiting cancer care to high-performing hospitals. Another option would be quality improvement projects that are aimed at improving quality of care in low-performing hospitals, which are actually most often likely to treat patients from the underserved community. Next slide, please. So let's look at insurance reform. There's actually evidence from the literature that insurance reform has had an impact in reducing disparities in head and neck cancer outcomes. So this was a study that used a SEER database and looked at the impact of Medicaid expansion on disease stage at diagnosis for head and neck cancer. And they looked at states that had undergone Medicaid expansion by 2014 and compared them with states that had not undergone Medicaid expansion. And what they found was that there was an increase in Medicaid insurance rates in expansion states relative to non-expansion states, especially for low income and low education counties. Similarly, they found a decrease in uninsured rates in expansion states relative to non-expansion states. But most importantly, they actually found that the rates of advanced stage at diagnosis decreased in expansion states, specifically for younger patients, female patients, and unmarried patients. And these are the populations that are most at risk for being uninsured or underinsured. Next slide, please. So let's look at regionalization of cancer care. So although, to my knowledge, there's no study that's looked at this for head and neck cancer, there's actually evidence that this has helped reduce disparities in breast cancer. So in 2009, New York State Medicaid program instituted a policy that they were not going to pay for breast cancer surgery in hospitals that perform less than 30 cases a year. And this study here took advantage of that natural experiment. And what they did is they compared patients that had Medicare coverage only, so high socioeconomic status patients, with patients that had dual Medicare and Medicaid coverage, so low socioeconomic status patients. And then they compared mortality before and after the policy was instituted. And what they actually found was that for the low socioeconomic status patients, there was a huge decrease in mortality rate. And 53% of this drop was actually attributable to the regionalization policy. Interestingly, this effect was not limited to the low socioeconomic status patients. The high socioeconomic status patients also noticed had a significant drop, although at a lower level. Next slide. So we should also look at potential options for reducing disparities of the healthcare system. So one option would be partnerships between high-performing tertiary care hospitals and safety net hospitals to help facilitate transfer of patients, cancer patients, to higher level of care, but also to provide a forum such as a tumor board for patients that are being treated at these sort of safety net hospitals to get expert level consultation for care there. Another area that we need to look at is expanding insurance access. A lot of healthcare systems limit the type of insurance plans they take, excluding plans that do not pay well, and some healthcare systems don't even accept patients that don't have insurance. We also need to look at patient navigation programs to help patients from socially disadvantaged backgrounds and also patients with low health literacy to better navigate the healthcare system. The healthcare system is already complex as it is in the U.S. But cancer care is even more complex than regular health care. And then we need to look at targeted interventions to improve access for specific underserved populations. So, for example, at the Stanford Head and Neck Cancer Clinic, a few years ago, we noted that non-English speaking patients had higher no-show rates than English-speaking patients. And we did a quality improvement project that ended up reducing the no-show rates for this population down to 0. We also need to look at provider and patient encounter level as well. An important factor here is diversifying our workforce because there is evidence in the literature that situations where there's concordance for race and gender in the patient-provider dyad actually leads to better interactions. We also need to think about potentially including routine social risk assessment when we're caring for patients. This will allow us to deliver precision healthcare. Generally, when we think about precision healthcare, we think about looking at genetic or molecular markers, but I think we need to be able to deliver individualized care that's tailored to the needs of the patient and also accounts for social disadvantage. And finally, we also need to look at addressing cognitive bias. And I think the most important step in this is acknowledging that we all have cognitive biases, and also, as Dr. Sykes mentioned, instituting provider education on how to identify and address cognitive bias. Thank you.
Thank you for that insightful talk and continuation of the previous talks in terms of themes. And our final talk for tonight is by Dr. Hamilton. He's an assistant professor in the Department of Otolaryngology at Grady Memorial Hospital in Atlanta. He completed his otolaryngology training at Thomas Jefferson University in Philadelphia, and then continued on to fellowship in head and neck oncology and reconstruction at Emory University. I think his talk is very well timed at the end, and all these, and how we actually this knowledge into for addressing. So thanks, Dr. Hamilton, for closing this out.
Great. Thanks very much for that introduction, and thank you all for inviting me to participate. I am going to talk about translating knowledge of disparities into action. What can we do? Next slide. I have no disclosures. So far, we've been discussing and illustrating the presence and effects of healthcare inequalities among population groups with regard to head and neck cancer care and outcomes, which is, as we've seen, increasingly reported in the literature. And most of these reports note, as we've seen, higher incidence in mortality, greater stage of disease, and worse oncologic and treatment-related outcomes for groups of patients, including those who are Black, socioeconomically disadvantaged, male, among others. And historically, published data in otolaryngology has focused on identifying the presence of these disparities and offers much, much less in the way of understanding what drives them. And even less, there are very few feasible measures to address these disparities that are presented. Now, more recently, there has begun to be a transition in focus from documentation and recognition to proposals of more targeted research and discrete interventions aimed at reducing or eliminating these disparities. Next. And a good illustration of this is a recent, very thorough, systematic review published in the White Journal a little over a year ago. Dr. Sykes was an author on this, so I hope I do it justice. And what the authors found was that health disparities research for head and neck cancer is abundant. However, these studies do offer minimal guidance on innovation with regard to study designs for research, hypotheses for driving factors, and most relevant here, discussion on potential interventions. And they looked at nearly 150 articles from the existing disparities literature dating back to the 80s, but the lion's share of those were published after 2010. Fewer than half were published in the otolaryngology literature, and only a little more than 40% offered anything in the way of specific recommendations or ideas for interventions that would help reduce or eliminate health disparities. Next. The authors categorized recommendations and interventions into 4 broader themes or focus points toward which efforts for change can be directed. And they are, as you see listed here, patient safety or quality improvement, which includes addressing improved screening practices, the implementation of patient navigation pathways, and implicit bias awareness and trainings. Patient education, largely behavior modification, most specifically with regard to cancer, tobacco cessation, but also other educational initiatives, targeted counseling and information. Health policy, with things targeted toward increased access to care, changes in vaccination practices, and targeting allocation of public health efforts and funds. And finally, cancer care and treatment, through which they address the need for personalized medicine, the standardization of multidisciplinary care and management, and the development of focused survivorship plans. And with the time I have, I'd like to highlight some of the measures, sorry, next slide, that show promise. Dr. Megwalu described well the effects of changes to health policy, so I'd like to focus primarily on clinical interventions at the individual patient and provider interface. Next. So first up, under the patient safety heading, is a study that was the result of a head and neck cancer care team looking to improve the delivery of postoperative radiation therapy. And they asked the question, what are the characteristics of an intervention developed to assess delays and racial disparities associated with the initiation of guideline-adherent postoperative radiotherapy for head and neck squamous cell cancer? And to answer that question, the team developed a navigation-based multi-level intervention that targeted barriers to the timely delivery of adjuvant radiation at the patient, healthcare team, and organizational levels. They titled the study Indoor, and what they did was embed a trained medical social worker within the head and neck surgery team, who acted as a navigator. The navigator met directly with the patient for 3 sessions that were clinic-based and lasted about 30 to 60 minutes, during which they directly delivered patient education and created, or when necessary, updated their plans for postoperative radiotherapy. Asynchronously, they coordinated between the patient and the healthcare organizations to track referrals and ensure the completion of studies and appointments. Next slide. To develop the program, key barriers were identified, but I think what sets this study apart is the implementation of discrete intervention components to address them across the levels of healthcare delivery. At the patient level, the navigator's role was to educate the patient about the role of radiation and help minimize the burden of travel through coordination of transportation assistance. Next up in red, at the team level, the navigator worked to ensure communication between patients and providers was understood with regard to the intent and the timing of radiation, as well as with transitions of care across disciplines. And at the bottom, the organizational level, the navigator acted as a coordinator among increasingly fragmented healthcare systems to ensure that all referrals were scheduled and attended as planned, or rearrange them as dictated by any changes necessary in treatment to avoid duplication or gaps in care. And when they looked at their work, they found that the rate of delay when this was implemented was 14%, which is great compared to an almost 40 to 60% rate of delay nationally. When they looked at the enrolled Black patients, they found that all of them initiated their radiation in a timely fashion, and they were enrolled at a rate of 30%, which was about 50% higher than in their particular demographic. And that was because rates of delay among Black patients are as high as 65% nationally. No patients withdrew, and 93% completed all 3 of the navigation sessions. The navigator was tasked with a mean caseload of about 3.5 concurrent patients, and at this rate, 100% of the patients agreed that the navigator was helpful in solving challenges in starting radiation, and 92% were highly satisfied with the intervention. One drawback, obviously, is cost, which no information was provided at this pilot level, but you can see that would be a holdup among others. With regard to patient education, these initiatives were the focus of the second broader theme. With any education initiative, the application is in large part dependent upon the health literacy of the population, which, as defined by the NIH, is the degree to which individuals have the capacity to understand basic health information and services needed to make appropriate healthcare decisions. Are they equipped to do well? And the association between poor health literacy and health outcomes has been demonstrated across the spectrum of otolaryngology disorders. Closer to home, we did in 2010 a review of health literacy amongst patients undergoing total laryngectomy at Grady, and we found that 35% of the patients were documented to have either inadequate or marginal health literacy, which is bad in such a life-changing situation as having your voice box removed. Another study looked at all the patient-directed laryngectomy education materials that are searchable with a simple internet search, and found that nearly all of them were written above a 6th grade reading level, which is the level at which the American Medical Association and the NIH recommend. Next slide. So faced with this, we at Grady developed a manual designed to escort our patients through from diagnosis through treatment and survivorship. And we developed this with the assistance of our laryngectomy support group and our patient education specialists within Emory. When you look at what's available, it's not necessarily pertinent to the patients that we treat. And so we enlisted our Department of Surgery illustrators to come up with more simple and inclusive imagery that we could use to illustrate this manual. And when crafting the text, we consciously set out to put it at that 6th grade level. And we were able to accomplish a Fleisch reading ease of 67 and a Fleisch-Kincaid grade level of 7.4, which in layman's terms puts it at about an 8th grade reading level or the level of a Harry Potter book. We asked our experts about this, and when controlled for unavoidable words like laryngectomy and the terms we needed to describe equipment, we did in fact get it to a 6th grade level. So next slide. We now introduce this to our surgical candidates preoperatively by laryngectomy patients at our monthly support group, or during their initial inpatient stay. We have ambassadors that go and present this manual that we designed in a spiral bound and very durable fashion, designed to be carried with them and brought to every appointment. And as we've rolled this out, we found that patients and families report increased comfort and understanding with their diagnosis and treatment. And we're currently undergoing a new round of revisions with the addition of QR codes that are linked to training videos for things like drain management, stomal suction, and other frequently questioned directives that patients and families can access at will from their mobile devices. And going forward, we'll be working with the American Cancer Society to make this adaptable across institutions so that it can be adopted anywhere in the country. Next slide. With regard to the theme of cancer care and treatment, I want to focus on the implementation of multidisciplinary care and management as the standard in head and neck cancer. As was stated before, the risk of inefficiency and delay in the management of head and neck cancer is high across the board. And among systems that disproportionately care for the most vulnerable populations, this effect is compounded. So to help our patients navigate these complexities, we developed and implemented a multidisciplinary head and neck cancer clinic here at Grady in the spring of 2021, with the goal of establishing a one-day visit with the treating specialists from the 3 disciplines, surgery, rad-onc, and medical oncology, as well as ancillary services, and wanted to include a thorough discussion of all therapeutic options, a personalized needs assessment for treatment optimization of each patient that took into consideration the social determinants of health that may present barriers to care to that individual. Next. We conducted a series of plan, do, study, act cycles in accordance with quality improvement measures at Grady, and started out with a pilot to establish feasibility, revised it. To build momentum, we really needed to get buy-in from all participants because it wasn't necessarily the most convenient thing for everybody. But we ultimately launched it and then powwowed afterward to continue to mitigate inefficiencies, and have subsequently met quarterly to continue to expand and revise it. It's now been rolled out in lung, and our urology colleagues use it. And when we looked at our success, we compared the first 22 participants in MDC with the previous 44 who were seen in the traditional fragmented manner, and found that we were able to significantly decrease the time to treatment initiation from the date of diagnosis by almost 14 days, which represented a decrease of 22%, even with a few outliers. We were also able to increase pre-op consultation with speech, nutrition oncology, and the ever-elusive pre-treatment dental eval from hit or miss 50% to well up over 90% for all 3. It proved to be a long day for patients, but by and large, we've cut down the risk of noncompliance and no-show amongst patients who face transportation barriers from 4 or 5 potential visits to 1 in which they show up, preferably with a family member, and they leave with a planned treatment date and a start date. next. So what can we do going forward? So as we've said, changing our focus from identification to what can we do at the ground level, at the clinic level, to implement strategies that will change outcomes in doable ways? How can we revisit our clinic appointment, our patient-provider interface in ways that make it more accessible to patients? And how can we measure that? And something that I've grown increasingly excited about through a conversation with one of my surgical oncology colleagues here next is the development of collaborative studies. They formed what they called a safety net consortium, through which they pool data in hospitals that might have lower volume than large quaternary centers, and have examined with control for all of the things that affect patients in those vulnerable settings to see what works, what doesn't, and measure their performance amongst our peers when we look at those patients that are treated in the most vulnerable settings. It's something I'm excited about getting started in the head and neck space going forward. And I think that's all I have. So thank you all for listening.
Thank you, Dr. Hamilton, for really great examples on how to make change, on the ground. And there are, we're going to open it up to questions from the audience. There is a question. There are two questions. First, even though they're answered, I think it'd be really insightful to share with the group. One question is, initially directed to Dr. Megwalu about what do you think that cancer fatality, medical mistrust, or financial burden may contribute to the differences in the extent of head and neck cancer treatment, and how do you think we might start to address this disparity as clinicians?
Yeah, so I can address that. I didn't realize that everybody could get the Q&A. Yeah, so I think that definitely, I think financial considerations play a huge role. There is evidence in the literature that cancer care is very costly and puts a lot of burden on patients. But I think in addition to the direct cost of care, other financial considerations can also cause patients to deprioritize their care. And I've had anecdotal experiences with patients about this, where it's either I go to work to pay my rent versus I come in to get my radiation treatment, and that can actually affect the quality of care patients receive. This is also the other part is less studied in the literature, but there is some evidence that cultural experiences can affect how patients interact with the healthcare system. So, for example, there is a certain level of mistrust in the African American community of the healthcare system because of past history of experimentation. And that can actually cause patients to either not seek care early or to not, go with the recommendations of the treating physicians. Unfortunately, this is not something that's really been, adequately studied in the head and neck cancer literature, and I think that's actually an area for future research. Obviously, this would, need a combination, a mixed methods approach, a combination of quantitative as well as qualitative approach to be able to actually capture some of the lived experiences that these patients have.
Which is a great segue to the next question, actually, which is, it's known that using existing disparities like race alone isn't enough, but rather that the focus should be on the lived experience, like social drivers that Dr. Gomez, talked about. And so we don't really do a great job collecting this information, as has been, depicted by all the panelists. And so especially collecting information on lived experiences. So what are the group's thoughts and suggestions on collecting these data? I know, Dr. Gomez, do you want to address this?
Yeah, I can start. I certainly have thoughts, but I'm sure that other panelists do as well. In fact, I think many institutions are starting to incorporate, I know Epic, and I believe maybe Cerner, and others have this, what they're calling social determinants of health, I'm using air quotes, module. Really, those are measuring social risks, things like food insecurity, transportation, housing insecurity, which I think is a great step. I do think that there needs to be institutions that are rolling these modules out probably need to do more than just put them up and then expect that patients are going to fill them out, but also I think there needs to be, not that we want clinicians and healthcare providers to go through more and more training, but there needs to be, I think, some guidance provided on how to best use these. And also, we know that if we're asking patients to self-report this, we have to be prepared to do something about it, right? So I think that one thing we're trying to do, work within our healthcare system, is to really be able to get at measures of social drivers of health. And so through things like geocoding, we can actually fairly readily link in data on like social and built environmental factors. We can even move further upstream and look at and link in measures of segregation and area deprivation, and even these measures of structural racism that I talked about. But there's also at the multi-level, experiences with discrimination and medical mistrust. And again, we don't want to burden patients to have to provide more and more information, but I think that maybe, that there may be opportunities to think about how best to incorporate those, or at least to assess those lived experiences as well.
I think if I can jump in on just one thing around the social risk management and sort of assessment. I think the unfortunate thing is that there are payers that are driving this conversation toward doing this without any sort of instruction on how to implement it. And so you're getting an enormous amount of variability in the implementation across the different health systems. You're getting differences in, are these self-completed? Are they completed by an MA? Are they asked in an appropriate and fair way? Are people really given the opportunity to be honest and comfortable with the opportunity to be honest? And I think that's the problem. And we're sort of digging into this at my own institution now and asking questions about how is this being implemented across the system, and how do we understand what it really means, if it means anything at all. And it's unfortunate, right? We don't want to be the naysayer and say, like, you're wasting your time doing this, but at the same time, there's a great concern for pointing out these types of social risks without any real context and understanding how someone might be interpreting those questions. And to Dr. Gomez's point, I think we could do more in the context of linking people's home address or their historical addresses to some of these kind of more global or I guess census-based or other area-based measures, and really feel fairly confident that we understand kind of what are the circumstances from which this person is coming, but then creating opportunities for people to have advocates that can speak to the barriers they may be experiencing, and that's embedding social workers, it's embedding others around the team, and really truly choosing that multidisciplinary approach.
I think this touches upon a really important question. Are we doing a service about asking these questions if we can't provide the services to address these, issues? And I think having the sensitivity surrounding that, which leads to how can we make these interventions like patient navigators, social workers, scalable, especially in healthcare worker shortages and resource, deplete, geographic regions and healthcare settings. And so I think that is a challenge from an implementation standpoint.
And that's where we have to, as advocates, push payers to not only say, let's measure it, but let's do something about it. And that can't only be the responsibility of the healthcare system or the cost associated with providing care. There has to be reimbursement models that include, social risk, some sort of addressing social risk and figuring out ways to support this. I don't know what other institutions are doing, but I think a lot of institutions are trying to pull together philanthropic funds in order to cover this effort. And at the end of the day, that's not where the majority of the money is coming into the front door of a healthcare system. So it makes more sense to me that if a payer is asking us to assess these things, then the payer might also be responsible for helping address these things.
We are coming up on the the end of the hour, and are there any last minute thoughts from any of the panelists? There are some questions that we can address in the chat, through typing if anybody has a specific question. But any last comments from the group? Parting words. Okay. Well, thank you for, again, starting a platform for these really important conversations, which ultimately, I think, lead us to more questions, but more opportunity for implementation of solutions. So thanks again, and we'll do our best to anybody who wants to stick on just to wrap up these questions in the chat. So thanks a lot.